day. I welcome you to this session on menopause, hormone replacement therapy, and andropause. I am Professor Balogun Olayinka Rabiu of the University of Ilorin, Kwara State, Nigeria. I will begin by giving us a good definition of what menopause is. Menopause is derived from the Greek word menos, meaning monthly, and pausis, which means cessation. It is defined by the WHO, World Health Organization, as a point in time of permanent menstrual cessation due to loss of ovarian function. Clinically, it is defined as cessation of menses for minimum of 1 year duration. So you cannot make a diagnosis of menopause until the event had passed. So it makes menopause to be a retrospective diagnosis. Events leading to eventual cessation of menses usually starts a few years prior to menopause, and this period is known as climacteric. Menopause is an important aspect of post-reproductive health. It is now estimated in the developed world that many women will spend up to a third of their life in the post-menopausal period. The average age at menopause in the United States of America is about 51.5 years, and the average life expectancy is about 82 to 83 years. The average age of menopause in Nigeria is 48 years, and the life expectancy is about 60 years. So that means an average, woman in Nigeria has about 12 to 15 years to spend after, cessation of her periods, and whereas the ones in the United States of America has about 20, 30 years, to spend. Pathophysiology of menopause. The fundamental etiopathogenesis is due to ovarian failure from ovarian senescence. It results in marked decline in ovarian steroid production. This hypoestrogenism results in a series of neuroendocrine changes, including decreased serotonin levels that produces the mood changes, increased central noradrenergic activity, which has been implicated in vasomotor symptoms. This in turn produces a lot of symptoms seen after menopause. Of course, menopause have clinical presentation, and the manifestation of menopause can be described as early. If it comes early, most of the time it is the neuroendocrine symptoms that the patient presents with, and these symptoms include vasomotor symptoms, irritability, insomnia, anxiety, memory loss, and decreased libido. Becomes early complaints that most patients have. The intermediate complaints or symptoms will include dyspareunia, postcoital bleeding, urethral symptom, and most of these symptoms can result from rapid loss of collagen associated with hypoestrogenic states. The intermediate symptoms can now be said to be more of vaginal dryness. And of course, vaginal dryness is as a result of the hypoestrogenic states. Late complications would include osteoporosis, which is as a result of marked decrease in bone mass. A lot of times, the bone mass is considerably reduced because of the hypoestrogenism, and not adequate bone is replaced. Hence, the bones becomes weak, and this is what is called the osteoporosis. Increased vascular risk, because we also know that the estrogen states also does have from protective effects on the cardiovascular system. Now in the hypoestrogenic states, the protective effect of estrogen is withdrawn. Hence, we now have increase in cardiovascular risk for patients in the menopausal age. This lipidemia, of course, we also know that we have ratios of all the various lipids within the system, and this ratio of high density, low density cholesterol are maintained by high estrogen level in the reproductive age years. In the apoestrogenic phase, which occurs in menopause, of course, this lipidemia does occur, and it also has its own implications. Vasomotor symptoms. The concept of thermoneutral zone was proposed by Robert Freeman. In asymptomatic women, core body temperatures fluctuate to the tune of 0.4 degrees centigrade and do not produce compensatory autonomic response like flushing and sweating. In symptomatic menopausal women, the low estrogen levels leads to narrowing of this thermoneutral zone such that a little core temperature fluctuation produces symptoms as flushing, as sweating, as being jittery. Vasomotor symptoms are produced due to the exaggerated tone of the central noradrenergic neurons, which results from hypoestrogenism. Obese women, however, have minor symptoms due to the fact that they have a very high level of circulating estrogen, which is another form of estrogen, but not as effective as ethinyl estradiol. If you want to evaluate, a menopausal woman, diagnosis is usually made clinically. However, some investigation may be required in some instances, especially in patients presenting with features of menopause at a younger age, which we want to refer to as premature ovarian failure. And in this type of patients, gonadotrophic acid, follicle stimulating hormone, if it is higher than 40 international per liter, is diagnostic. Karyotyping may also be done because you may also be seeing the patient for the first time and may have tonal mosaics. And if this feature occur, that means karyotyping becomes important. Lipid profile, of course, once menopause sets in, there will be lots of ratios, normal ratios between the various classes of lipid formulations that we have in the blood system. Of course, the DEXA, the clotting profile, and AMH, anti-miliary hormone for the ovaries should also be assessed. What are the interventions, for the vasomotor, symptoms? One, importantly, lifestyle modification, regular exercise, to quit smoking, to stop or reduce alcohol intake, and to encourage diet that is rich in isoflavones and to eat balanced diets. For most of these patients, it's enough for you to counsel them, explain to them what are the problems, and for most of the times, if you succeed at letting the patient understand the various interface that they are going through, it suffices. And most of the times, talking to them, giving them support may also have done a lot for most patients. Non-hormonal intervention for vasomotor disease are, well, the use of raloxifene is approved for use in this regard. It selectively provides egoist actions on the bone, the cardiovascular system, while sparing the endometrium and the breast. However, it has no effect on vasomotor symptom itself. Base-doxyfen is another that we can use in this regard. Tissue-selective estrogen complexes, which is also called TSEC. Combination of these are gradually being introduced to address these problems in patients who do not have good relief from lifestyle changes, taking some exercises and improving on their diets. Of course, we have gels for vaginal dryness, and some of these gels are hormonal, contains estrogen, which can be absorbed directly from the vaginal orifices. Calcium supplementation may also help. Vitamin D, calcitonin, bisulfates, alpha-2 agonistes, and fluoxetine and the fluoxetine that we've already discussed, gabapectin, and denosumab, a monoclonal antibody with anti-resorptive properties, may also be applied into some patients that are not responding to our supportive counseling sessions. Complementary therapies such as the use of phytoestrogens found in soy products and red clover, phytoprogestins, vitamin E supplementation, acupuncture have all been tried with conflicting reports. A patient who have a very severe vasomotor symptoms certainly needs some form of support, and whatever it takes for to support the patient, to relieve her of her symptoms, to relieve her of the anxiety, to make her to sleep well, are all have been utilized with various conflicting conclusions and reports. Other interventions in postmenopausal period include treatment of depression, addressing urogenital problems, dental care, and providing social support. Hormone replacement therapy. The primary indication for hormone replacement therapy is relief of menopausal symptoms. Low dose of estrogen preparations are being encouraged to limit the associated side effects without compromising the effectiveness. Bioidentical hormones provide effective amelioration of menopausal symptoms while limiting the undesired adverse effects. The ideal agent will be that will limit bone resorption, protects cardiovascular system, effectively blocks vasomotor symptoms without undesirable effects on the endometrium and the breast. Unfortunately, no ideal agent is available today. Estrogen comes in various forms. We have the conjugated equine estrogen. We have the micronized estradiol estrogen valerate. You have the transdermal estradiol. You have estradiol implants. You have estradiol vaginal gel. Transdermal estradiol appears to have the least effect on thromboembolic phenomenon because the first pass metabolism of oral estradiol results in estrogen production, which increases the risk of thromboembolism. Progestogens. It is recommended that progestogen should be given for 12 to 14 days per cycle to protect the effects of the estrogen, undesirable effects of the estrogen on the endometrium. It is not necessary in hysterectomized women except there is evidence of residual endometrial tissue after subtotal hysterectomy. That is, in patients who have had a total hysterectomy, progestogen may not be that adequate or necessary. It can be given as sequential combined hormone replacement therapy or a continuous combined hormone replacement therapy. The side effect of progestin inclusion will include fluid retention, bleeding problems, and androgenic side effects like hirsutism or acne. So, all these things should be looked out for in patients who have intact uterus and who are desirable to have a complementary progestogen added into their hormone replacement therapy. You do not need to have a complementary progestogen inclusion in women who have had hysterectomy because the progestogen itself is meant to protect the endometrium. And in the patients who have had hysterectomy, no more, the uterus is not there, The endometrium is not there. We do not need to include progesterone combination in our hormone replacement therapy. Examples of progesterone for hormone replacement therapy include levonorgestrel, nevoregeneration intrauterine system, medroxy progesterone acetate tablet or injection, norethiosterone tablet or injection. Cyclogests, can be used as a progesterone component in hormone replacement therapy. Androgens for women experiencing profound loss of libido with associated tiredness, androgens from preparation should be considered. This is referred to as hyposexual desire disorder, HSDD. Testosterone can be given as transdermal patches, vaginal cream, preparation for this purpose. If testosterone levels are kept at physiological range, hirsutism and acne are rare. DHEA levels are severely low in menopausal women and have been implicated in the aging process. Supplementation with DHEA is now being evaluated as an anti-aging medication. Tibolone is a synthetic steroid with weak estrogenic, prosterogenic, and androgenic properties. It can be used effectively as a form of continuous combined hormone replacement therapy. Side effects will also include bleeding problems and androgenic side effects. Bleeding problems because estrogen is there, progesterone is there. Androgenic side effects because it also has androgenic properties. So you must look out for it, hirsutism and acne as part of review that should be done for a patient that is on tibolone. Andropause. Andropause is derived from the Greek word andra, meaning woman male. Pausis means cessation. It can be defined as a state of decline in the feeling of general well-being with associated diminished sexual satisfaction and usually with declining testosterone levels, which occurs in older men. It is a form of late onset of hypogonadism. Wenner in 1946 produced a landmark report on andropause and he described it as male climacteric. It is also referred to as ADAM, androgen decline in aging male, or LOH, late onset hypogonadism. Androclase or male menopause. Unlike menopause in women, andropause is usually insidious in onset and it is not commonly associated with absolute or abrupt gonadal failure. In the actual sense of appellation, andropause, it occurs in men who have lost testicular function due to disease, accident, or androgenic causes like surgery. The exact prevalence of andropause is difficult to define. In one report, the prevalence of hypogonadism was 3.1 to 7% in men aged between 30 to 69 years and 18.4% in men 70 years and above. The prevalence of symptomatic androgen deficiency was 5.6% in men 30 to 79 years. Just like in menopause, the pathophysiology in andropause is also a situation where we have testosterone levels declines at the rate of 1% annually from the age of 30 years. Usually, manifestations of andropause are in middle-aged women with prevalence increasing with age. Signs and symptoms of andropause cannot solely be attributed to androgen decline, as some men with low testosterone levels do not show symptoms. Decline in other anabolic hormones are also involved. Severity of signs and symptoms also show poor correlation to the level of the serum testosterone. Decline in free testosterone levels is central to this pathogenesis. This can be worsened in the face of chronic medical conditions like obesity, diabetes mellitus, chronic stress, which can alter the production of serum, hormone binding globulin, SHBG. Other conditions that can accelerate the development of andropause include drugs, especially cimetidine, spironolactone, antidepressant, alcoholism. All these drugs can accentuate the development of andropause in any aged man. And the clinical presentation include declining libido and, of course, erectile dysfunction, fatigue, decreased muscle mass and increased body fat, irritability, memory loss, depression, osteopenia, poor sleep, odd flushes too can occur as a symptom in andropause. Diagnosis of andropause. It requires the presence of symptoms in the presence of very low level of testosterone levels. The European Male Aging Study recommends the presence of 3 sexual symptoms, i.e., low libido, loss of early morning erection, and erectile dysfunction with total testosterone level less than 11 nanomole per liter, or free testosterone less than 220 picomole per liter, as making a diagnosis for andropause. Treatments. It includes ameliorating many of the symptoms of andropause, which includes some improvement in bone density. It is absolutely contraindicated in clinical prostatic cancer and breast cancers. In effect, on subclinical prostatic disease is yet to be determined. There are different preparations which include patches, gels, and intramuscular injection of various testosterone preparations as being highlighted above. So, in summary, menopause is a retrospective diagnosis. Andropause is also a retrospective diagnosis. Most of them, the menopause affecting women in the old age, andropause affecting males in the old age, and both of them, both the menopause and the andropause, are also features of declining in the male organ, function. And luckily, most of this decline in functioning, glands, either in the males or in the females, occur with old age. Occasionally, we still find these same features occurring in early ages, but most of the times they are associated with significant other medical conditions. So therefore, if we have a case of menopause occurring in ages less, than 45 years, you should get worried, and such patients must be adequately evaluated to get to, the medical condition that, has precipitated the development of the symptoms in the individual. Same goes for andropause. And if all these measures are taken, most of the times, we're normally going to have a successful management. I thank you for listening. Thank you very much.